Hello, this is Kim Jong-il. Today, we will have the second lecture on treatment by using headgear, specifically the production and adjustment of headgear. It is convenient to use manufactured headgear. First, we need a model of the patient's maxilla. We need marking pencils and young pliers. As we can see, the headgear has a diamond point. Make sure this diamond point is always facing upwards. It should always face upwards, including when the headgear is worn. In order to do this, we have to flip it like this for the cast. We mark the center on the opposite side and draw the contour of the arch to fit the dental arch. We can perform arch contour to widen the arch like this. The headgear inner bow is inserted in the round tube of the maxillary first molar. In order to form a stop, we can A. Weld a spacer. B. Bend in an inward direction opposite the molar offset. C. Apply a U-shaped loop. You may choose any one from these three methods. I personally recommend choice A. But today's lecture will focus on choice C. First, mark the entrance of the tube of the maxillary first molar. When marking, there should be a 3 to 5 mm space between the junction and the maxillary anterior region. It is important to create this space before marking. When bending the U-shape, start bending the wire 7 mm in front of the marking. The wire is 1 mm thick, and considering the two ends of the loop, we need 2 mm. Use the round beak of the young pliers to bend the loop, and a 5 mm diameter loop is created. 2 plus 5 mm equals 7 mm. This is why we start bending 7 mm in front of the marking. This is how we apply the U-shape. Bend both the left and right side. In this case, the loop was bent facing upwards. However, bending the loop downwards toward the occlusal surface makes it much easier for the patient to wear the headgear by oneself. Prior to using the headgear, the maxillary dentition must first be aligned to derotate the maxillary first molar. Derotate tooth number 6 by using an open coil spring on the anterior of the tooth from tooth number 6. Then take an impression for making the headgear. Use the impression to make the headgear an ABP. Adjust the headgear and deliver it to the patient. Explain to the patient how to use the headgear. Have the patient practice wearing the headgear by oneself before leaving. Also explain the precautions to the patient when wearing the headgear. The headgear and ABP are usually used together. I normally use cervical headgear. The use of cervical headgear delivers orthopedic force to the maxilla, and the use of anterior bite plate brings the effects of functional appliances. These effects are maximized when used simultaneously. We can use the two Keckers 4 appliances by bracket bonding, tooth number 1, number 2, and number 6. We can also bond the bracket on tooth number 1, number 2, number D, and number 6. We may then use the open coil spring. After the derotation of tooth number 6, we can take an impression for the headgear. First, apply the band in the patient's mouth, weld the double buccal tube, and cement the band. The double buccal tube has a rectangular tube to insert the arch wire and a round tub to insert the headgear inner bow. Would it be better to place the round tube towards the occlusal surface or towards gingival? Gingival placement of the round tube would be more effective. This is because it allows us to exert force close to the center of resistance of the tooth. However, gingival placement of the round tube makes it harder to maintain oral hygiene. From the perspective of oral hygiene, placing the double buckle tube towards the occlusal surface would be better. There are 3 ways to apply a stop to the headgear inner bow. Firstly, we can locate the U-shape towards the occlusal surface, making it easier for the patient to wear, and prevent the loop from pressing the gingiva. Secondly, we can weld the spacer. Thirdly, we can bend inwards. The headgear inner bow is inserted in the round tube. When the inner bow stop is caught in the round tube, there should be a space of 3 to 5 millimeters between the anterior junction of the headgear and the maxillary incisors. The junction would touch the maxillary molars if there is no space. Even if we do create such space, the junction may still touch the maxillary molars when the first molar moves posteriorly. In this case, we can weld another spacer. When we first insert the inner bow, one side of the inner bow goes in smoothly, the other side may not. The direction of this side of the inner bow may be different from the direction of the round tube of the first molar. In this case, we should adjust the inner bow to face the same direction as the round tube does. Insertion is easy when both directions of the inner bow align with both sides of the round tubes. Insertion is difficult, even for professionals. Needless to say, how hard it would be for patients to insert it themselves. If the maxillary tooth number 6 is mesially rotated, we can use the headgear for adjustment. But again, the patients would not be able to do it themselves, so we must derotate tooth number 6 first. When adjusting the headgear, make sure that the directions of both inner bows are parallel to the directions of the round tube. Next, we must check the direction of the outer bow. We usually use the long outer bow. Even when the cervical strap is attached, the outer bow must be positioned above the maxillary first molar. In other words, it should be positioned on the same line as the posterior alar cartilage, or the level of the nose. We must then train the patient on how to close the lips properly. It is important for the lips to locate at the junction, the border between the headgear inner bow and outer bow, when they are closed. Magnitude of force applied would be appropriate with 400 to 500 grams. The recommended wearing time, excluding school hours, is 12 to 14 hours, including sleeping hours. When we look at the clinical management, only the anterior bite plate is worn first. The anterior bite plate itself can eliminate the occlusal force, which could push the mandible forward. Inform the patients to keep it on at all times except when eating and brushing teeth. Also inform them to keep their lips properly sealed. The patients will be more comfortable with the ABP after a week. Apply the headgear after a month and inform the patients the precautions. Make them wear it for at least 14 hours a day. Unlike the general face mask, the headgear needs to be worn for 6 to 9 months to obtain desirable results. Wearing the headgear may move the maxilla posteriorly and the maxillary dentition distally. Over time, the outer bow of the headgear may descend. We must check and adjust the position of the outer bow. The inner bow must be adjusted so that the headgear is located at the center of the lips, and the outer bow above that. This is a 10-year-old female patient. Her CC was spacer and protrusion. She has an excessive overjet. There is spacing in the maxillary anterior region, and tooth number C, yammer D, and dummer E are in retention. We must first have a skeletal analysis. The ODI is 81.5, APDI 75.5, and CF 157. This is a case of Class 2 low angle. We must attach brackets to tooth number 1, NOR 2, or D, and NOR 6 to derotate the posterior region and use the open coil spring, followed by wearing the headgear to complete the treatment. This patient's mouth tends to open slightly. In such cases, it is important to inform patients to keep their lips sealed properly. The APDI changed to 80.5, and the ODI and CF also changed. It is now a Class 1. The vertical dimension of this patient increased by using cervical headgear. Because the patient's lips were not sealed properly, the mandible rotated backwards and downwards clockwise instead of moving forward. The ODI of 81.5 decreased to 71, and the APDI of 75.5 increased to 80.5. Using the headgear causes the maxillary molars extrudes. This extrusion of the maxillary molars can push the mandible further forward. If the lips are not sealed properly, there's a high chance that the mandible rotates backwards and downwards, resulting in undesirable consequences. This is a case of Class 2 low angle with ODI 80, APDI 75, and CF 155. Because the combination factor is big enough, we can take 5 from the ODI to make the APDI 80. In this case, non-extraction treatment would be possible. This is a case of Class 2 high angle, ODI 75, APDI 73, and CF 148. The direction of growth for this patient is backwards and downwards. We must remember that the mandible is likely to rotate backwards and downwards because the combination factor is small, regardless of the big ODI value of 75. In this case, it would still become a Class 1 high angle regardless of treatment. Therefore, there is a chance we may need to extract a tooth somewhere. We must first evaluate the edge-to-edge bite profile. What does having a bad edge-to-edge bite profile mean? It means that the maxilla is protruding, or that the lower anterior facial height is long. We use headgear plus ABP on growing children with a large combination factor. Here, we must look at the combination factor instead of ODI for an accurate vertical skeletal analysis. This patient has a combination factor of 156. On the other hand, this other patient has a combination factor of 148, but a large ODI value of 76. We must not diagnose this patient with deep bite. Clinically speaking, there are not many growing children with a protruding maxilla and a large combination factor. These are patients subjected to be used headgear plus ABP. For patients who are not adults, those with small combination factors, etc., I recommend extracting a tooth somewhere instead of using headgear. In order to use cervical headgear, all 3 following conditions must be satisfied. Class 2 low angle. The combination factor must be above 155, the mouth should be slightly protruding, and the maxillary second molar should not have erupted yet. The UOP and POP may have normal values, but the UOP may be steep. If the cervical headgear is used satisfying all these conditions, we can achieve desirable results. Thank you for watching.